Hello, good afternoon, everyone, and Happy New Year. My name's Sue Hines. I'm Head of Services at Dementia Carers Count. And we're doing a slightly different format today to our Facebook Lives. This is going to be the first in a series of 3 sessions, which we're calling a carer clinic with Dr. Raja. He is practicing elderly and dementia care specialist. Thank you so much for joining us, Dr. Raja. And he's going to be receiving lots of questions from everyone today in this session. Would you like to introduce yourself, Dr. Raja?
Oh, hi, Sue. Thanks for inviting me. And yes, I'm Raja. I'm an old age psychiatrist by profession, and I have a broad breadth of experience having looked after people with dementia in community mental health services, inpatient services, and liaison services in acute hospital, as well as having had the experience of running older adult mental health services as Associate Medical Director during the COVID times. So I'm hoping that I could draw upon all these experiences to answer some of the very important questions that people will have about dementia. And it's good that we're doing it as a 3-part series, and perhaps it'll be good to tell people about what these 3 parts constitute at this moment in time.
Yeah, that would be fantastic, Raja. I think, as you say, these sessions are going to be invaluable to carers. So we've tried to break it down into 3 consecutive sessions, but they stand alone, don't they? Could you tell us a little bit more about those?
They are standalone sessions. The first session is about what are the common symptoms of dementia, what is the diagnostic processes involved, what services do get involved at the point of diagnosis, how would the carers have to deal with the point of getting to know the symptoms and getting to the point of diagnosis. So we're going to focus on all of those things in the first session, which is today. And in the second session, we'll be focusing more on what are the different types of dementia, and therefore how they could present in many different ways, and hence the variability in terms of impact on carers. And that's going to be the focus of the second session. And in the third session, we'll be focusing more on treatments, supports, and services, which can be very useful for both the individual with dementia and their families and carers who are involved in this difficult, challenging journey that they will be facing.
Thank you. And it is difficult and challenging. And I think one of the things, Raja, that you and I spoke about was in session 1, we'll look at the symptoms and diagnosis. And I know you're going to touch today as well that it's not always the symptoms turn out to be a dementia. There can be other causes. So there's an importance to that. The second one around that, the different forms of dementia and how a diagnosis takes place, and then the medications. But I know you feel really strongly the same as I do, that for Dementia Carers Count, it's also important for us to acknowledge and cover that emotional support and the fear that can come both for carers and a person who perhaps is going through the diagnosis themselves, at all of those different stages as well.
Absolutely true, Sue. So there was this study which was recently published online, which said that 50% of the population in UK has come across or has known someone with a dementia. And that is a very significant number in itself. It's mainly grandparents and parents who have had dementia, and then the family has to cope with the consequences of it. And that is a very anxiety-provoking, frightening experience to start with. And that's why it's very important for us to recognize the important role that carers play in the journey of dementia diagnoses, and also to make them aware of what are the support structures that are available that they could count upon. Because one of the statistics is that about 50% of people who care for someone with dementia will face clinical depression at some point of time in their life. And that is something that we would really want to avoid. And if it does exist, we would want to help people and treat them at the earliest opportunity.
It's huge numbers, isn't it? It really is when you look at the statistics.
Absolutely. And it's also important for people to understand that dementia is the leading cause of mortality since 2017. If you exclude COVID-related deaths that we faced in 2020, then dementia is the leading cause of mortality. And hence it has got a significant impact on relationships. And equally, it's the most feared diagnosis of our times, according to the population who were part of this particular study. And despite dementia becoming more discussed about topic in various forms of media, people are still frightened about thinking about dementia as a possibility for some of the symptoms that they experience. And it's also, and it means that there's a kind of reluctance to go to appropriate services to get themselves tested or investigated for a possible dementia. So I think we would want to try and talk about symptoms today, so people are more clear about what to look out for. We'll also touch upon some of the other explanations for memory problems, and hopefully people will become more fairly confident in understanding the symptoms of dementia and trying to know what services to contact and what to expect as part of initial assessment.
Great, and we'll move on to that now, but I think that fear is a really important one, and what you say about people's fear because of everything in the media and stigma, I guess, that's associated with diagnosis. And hopefully the resources that we provide through Dementia Carers Count Virtual Carers Centre and our live onlines can try to take away some of that fear and stigma alongside the valuable information that you're going to give us today as well. So I know that you have developed a particular tool that is used in community hospitals, and you've had some great outcomes from using this tool in community hospitals. And we felt it would also be useful for carers as well as staff in hospitals. So I wondered if you could tell us a little bit about that tool that you developed that looks at the early signs and symptoms that somebody might see.
Absolutely, Sue. So this was something that I developed in 2013, so it's been there for about 9 years now, at least 9-10 years. It's based on the fact that stroke is a very lethal illness, and as a kind of public awareness campaign, the Department of Health came up with FAST as an acronym for some of the symptoms of stroke, and I just felt that we should have something very similar to dementia, so people can actually relate to, recognize, and then try and seek the right help. But equally for clinicians who may not be specialists in dementia, like primary care GPs, nurses, or acute hospital clinicians, could then spend at least 5 minutes of their time trying to understand what symptoms an elderly person could be presenting with if dementia was a potential diagnosis to be considered. So based on that, all of us know that forgetfulness is the most common symptom of dementia. So I thought we could use forget as an acronym, and then we could build on that as a way of trying to recognize the symptoms of dementia. So if we take the first symptom to be forgetful, but just take forget as the word, then we could use F to say failure to recognize familiar faces. And that could be family members, that could be friends. You would often find that people with dementia will say, oh, I know the person, I can see them. Or even when they see the person, or see their grandchildren, or some of their friends that they haven't seen for some time, they'll say, oh, I know you, I know. And then the name may not come to them immediately. So that sense of failure to recognize familiar faces would be what F is for. O is for odd behavior or odd thoughts or beliefs. And that would the kind of more common things would be such as people misplacing things and then coming up with a plausible story as to why they can't find something that they should be able to find. Or sometimes even saying that, oh, well, I don't know, someone took it, it's been stolen, etc. So that's a very common odd belief that people could have, especially if they have carers coming in. They might have misplaced their glasses, or they might have misplaced the remote control of TV, and then it becomes a problem. Odd behavior could be someone engaging in unusual behaviors that are not part of their usual repertoire. So for example, and this is just a very crude example, if someone suddenly took up gambling online, and this is a person who is always risk averse, then we need to start thinking as to why is this happening at this particular point of time. So that kind of odd beliefs, odd behaviors would be for. R is for repetitive or reduced speech. So most of us would be familiar with someone with dementia asking the same question infinite number of times because they can't hold things in their memory that well, especially for recent events. So we might have said, oh, well, your GP appointment is tomorrow at 10 o'clock. And then we might have to have that conversation umpteen number of times until the appointment. So that kind of repetitive conversation. Or sometimes when people do get dementia, their vocabulary tends to reduce. So they may not actually say they need a cup of tea. They might come about saying that in different ways, or they might actually not say at all, and it would be the family who would have to try and guess as to what the person is asking about. So so that degree of reduced or repetitive speech is what R is about. And then G is about grooming problems. So problems in looking after themselves. And that could be variable. Sometimes people, because they're disoriented to time, they're disoriented to place, they might wake up at 4 o'clock in the morning, believing that they need to be at work and start getting ready when they've been retired for 10, 15 years. They would still groom themselves. So it's not a problem as in not being able to groom, but it's inappropriate in terms of time and context to it. Equally, you could also have someone who is not able to look after themselves to the degree that they would be looking after themselves previously. So wearing soiled clothes or not going to the hairdressers as regularly as they would, that kind of stuff. And I would also extend it to saying, well, if someone is very house proud and then you go to their house and it's not looking quite the state, then you do have to think about what is happening here. So it just reminds me that when I was a young trainee, one of my consultants used to advise me that you should go on a house visit. You shouldn't see patients in clinics. Go to their house. You'll learn a lot more about what dementia is. And then the trick is to ask them to make a cup of tea for yourself, and you will learn a lot from that. So it's that degree of looking after. So that's what G is about. And E is about evening restlessness or poor sleep. Sundowning is very common in people with dementia. Their brain's starting to get tired, get to 4 or 5 o'clock in the evening. They become a bit more irritable, unhappy, or becoming a bit aggressive. So that could be evening restlessness, or because they're disoriented to time, they may not sleep very well at all. So E is for evening restlessness and other sleep-related disturbances. And finally, T is having problems with toileting. So people could become incontinent as the dementia progresses. And in some rare forms of dementia, it could be the starting point of dementia diagnosis as well. So if you were to look at them collectively, there are about 7 symptoms: forgetfulness, failure to recognize familiar faces, odd beliefs, odd behaviors, repetitive or reduced speech, grooming problems, evening restlessness, and toileting problems. The important thing is to understand that these symptoms should be present for at least 6 months. So that is the major thing, because people could get one of these symptoms for a week in time. For example, if they're having an infection and they're acutely confused, then you could have one of these symptoms.
Thank you. Can I just stop you there a minute, Raja? Yeah. Sorry. Do you mind if I just interrupt you? Because I do want to come on to the idea of what you're just saying then. And I'm glad you re-summarised the FORGET acronym, because it meant that I didn't have to try and remember it. But we'll come on now to, sort of this has to be going on for some time and what some of the other reasons were. But now we've encapsulated that this session is around those signs and symptoms that you're looking out for. And I'm sure the acronym we can put in the chat and it will be really useful for people, is to say, anyone listening to this, we're more than happy for people to send in questions. If you want to ask Dr. Raja something about these signs and symptoms and moving towards a diagnosis, then please do put some questions in the chat for us, or private message us if you prefer to do it anonymously. If we don't get to all of those questions today, because we do only have that 30-minute slot, then Dr. Raja and myself and other members of the team will spend some time going over anything that we've missed, isn't it?
Absolutely.
So now I've interrupted you very rudely, Dr. Raja. I'll come back to you, and you were just saying about these symptoms. If they're just a week or so, perhaps you might think there's something else that's occurring for the person.
Yeah, absolutely. I'm sorry, I'm just going to cut off this call that's coming through on my. I think it's important to understand that dementia is a clinical diagnosis, and these symptoms should be persistent for at least 6 months, and there should be some degree of functional decline as a consequence to it. So it's not just becoming a bit forgetful, which is part of normal aging itself, but for the forgetfulness then to cause a significant impact on someone's daily activities, then that's when we start to consider, has it reached the point where it's important to consider dementia as a diagnosis. And that is why it's important to look at things like infections, because elderly people, when they get a chest infection or a urine infection, then there is a chance that they might become a bit disoriented, a bit confused. Sometimes people might start seeing things, and that could be very disturbing for the family carer. But that is something that people will recover over a period of time. It might take a week, it might take up to 12 weeks, but people will generally come out of that. That definitely is not a dementia. It is a delirium, and we need to recognize that and treat and avoid unnecessarily labeling that presentation as dementia. Equally, there will be other life circumstances that could explain some of the forgetfulness, at least. Like, for example, when people retire and they've got a routine that they are used to for about 30-40 years of their life, and then they have to try and build a different routine for them during the daytime and start filling the daytime with activities that they might enjoy. That might provide a bit of a stumbling block, and it might take a few weeks, a few months for them to overcome that. So, and that is part of normal aging and normal life changes that all of us go through. So it's important to understand that when there are life circumstances like someone retiring or losing a loved one, all of those will mean that we will have to adapt to certain changes in life, and that causes mental stress, and people might not register information as well as they could at that point in time. So that is why it's important that all those 7 symptoms that we talked about, we need to try and make sure that it's not that all symptoms need to be present. Some of them need to be present, but they should be present for at least 6 months, and they should have an impact.
Thank you. So not all of the symptoms, but a lot of the symptoms over a prolonged period of time that don't sort of just last a week or so and go away. Now, I think where what we often hear carers say is that perhaps they're at the point that they feel there are these symptoms that you've talked about in your FORGET acronym, that they've been lasting, and we think, yes, I've got a concern here. And then they find the information out there so overwhelming, and so much information, so much medical terminology, really difficult to navigate through when you're trying to think, who do I contact about a diagnosis, or how do I go about getting an investigation? What would be your advice to someone in that situation?
My advice is to contact the GP as the principal and primary point of starting this diagnostic journey. A lot of other services will join in at various points of time, but the GP surgery and your GP is the most important person in all of this, because they will then do some of the important blood tests to try and make sure that we're not missing out on things such as vitamin deficiencies or hormonal imbalances, or things that are related to old age, which could lead to some degree of memory problems. And then they will forward the referral to a memory service. And that is set up differently across various counties and home nations. But it's important to understand that there will be a secondary care service. A mental health trust will provide that. They might call it as a memory assessment service. They might call it as a memory assessment as a part of a community mental health team for older adults, but there will be a secondary care service who will receive the referral from GP and then arrange for a memory assessment to happen. And I would strongly suggest that someone who knows the individual with dementia very well, especially a family member, goes to that appointment, because a lot of history taking is going to be very valuable, not just with diagnosis, but also trying to understand the social circumstances and hence the support that will be required for the individual with dementia and their carer. Because part of the initial assessment, apart from history taking, doing a cognitive test of some kind, will also be having a carer's assessment, because we want to know how the symptoms of dementia not just affect the individual, but also the carers, because planning will involve planning for both the individual dementia and with carer. So we do an initial assessment, which involves cognitive assessment, history taking, and carers assessment, which is very important. And subsequent to that, there will be a decision made about further investigations, such as a brain scan. The nature of the brain scan or the necessity of the brain scan will depend upon the type of dementia, because there are some rare dementias which might need very intensive investigations, and we'll talk about them in our next session. But once those tests are completed, then it would be the point at which the family member and the individual with dementia will be called in to discuss what type of dementia, if it was dementia, and how to proceed from there. So to kind of summarize, GP is the most important person. Go and talk to your GP. They will forward the referral after doing some tests to a secondary care mental health service, who will then do a comprehensive assessment, including a carer's assessment.
Thank you. And just to clarify as well, that in that comprehensive assessment, sometimes the thing that's confused me in the past was, we often talk about a memory clinic, but sometimes it's almost a virtual clinic, isn't it? Because it's a cluster of home visits that are sometimes made. It's not always somebody comes to the clinic for those assessments. Some of it, as you said earlier, you were taught very early on in your career, go to the house, you learn so much from the home environment. And you mentioned about carers assessments, and I think there's two things perhaps we should clear up, is that there's a carers assessment, which, as you say, is so important to assess what the needs of the carer are and what they might need in the future to support themselves to do that. And then there's also the other reason that it's really important for a family member or carer to go to the appointment is because they will give so much of their assessment of the situation and what's been going on, which is it's two different sides, isn't it? It's one about you as a carer, what do you need, but also you as a carer, what really useful information can you give us that you've observed going on?
Yeah, absolutely. And I think it's dementia is an interesting illness in the sense that there will be times where the person with dementia may not actually be aware of the problems that they are having. Because they may not have enough insight into what symptoms they're facing, how it's affecting their daily lives, how it's affecting the loved ones around them. So that's why it's very important for us to have corroborative history from the carer. And you're right. I think it's not just a clinic, as in going to a hospital-based clinic. Most of the times these assessments will, at some stage, involve a member of the team visiting the home to see what is actually happening, and that is very crucial information to be had. And it also gives opportunity for the family member to talk in private, to talk in confidence, to express their concerns, because sometimes it may not be very easy to have a conversation with the person with dementia being present at the same time. So yes, so there will be a combination of home visits to hospitals, but there will always be time for the carer to express what they want to say, if not with the person with dementia being present in private.
Thank you. I can't believe the time is going so quickly, Raja. We're almost out of time already. So I'm just going to sort of move us on to something you touched on there, that the fear, we talked earlier about there being a fear of diagnosis. There may be a lack of insight by a person that there are any issues. But there's a whole host of emotions that are going on for both people who come to that appointment. And so the emotional support is really important as well. And it's often interwoven into those memory assessment services, isn't it?
Yeah, absolutely. I think the emotional support starts with the point when someone speaks to the GP and the GP understands the situation, starts providing that degree of guided journey through the process of diagnosis of dementia. But equally, the clinician who is part of the diagnosis will be providing that degree of support as well. And then there are other organizations, including Dementia Carers Count, who have got a wealth of information on your website, a lot of learning tools to be considered. So I think that would be very helpful. But equally, there are more more local services such as Mind or Dementia Navigators, some form of services provided by Aged Care UK, Alzheimer's Dementia. So all of these people will be very useful in providing that degree of emotional support. And some of these services may also provide a degree of respite to the family member who's looking after someone with dementia, even at the point of diagnosis or through the point of diagnosis. So, but all of these services could be accessed through primary care or through the mental health memory service. So it's very important to ask for information about these services because they're so very local. We can't provide as part of this conversation list of what is there for each locality. But what I would strongly suggest is that GP surgeries and memory assessment services, in whatever shape or form they're provided, they will have a list of carer support services that are available more locally, and also have information about things like dementia carers count. So that would be provided, but it's always important to ask if there are any particular needs that people who look after someone with dementia have. Then it's better to ask at the initial assessment, because as I said, it's a kind of two-way street. We get information from the carers, but we're also there to provide information to carers to have the right degree of support.
Thank you. And on our website, we have lots of information, as you say, but also signposts to many of those organisations that you've talked about. I'm aware we're in the last couple of minutes, so I'm hoping we don't get cut off. I just wanted to make one comment. We've had a comment in from Catherine who said her father was diagnosed 2 years ago with early stage Alzheimer's, but he's showing problems with coordination and feeding himself. And is that normal? I think one of the things to say perhaps is there is not necessarily any normal, is there? That it's unique for every individual.
Dementia is very unique for every individual, and the experience sadly cannot be extrapolated to others. But I think lack of coordination and challenges with feeding is part of dementia. Unfortunately, as it progresses, it becomes a significant problem. So it's important to contact the mental health service provider and to seek guidance in terms of what could be tried and assisted. One of the things that we used to do when I was a ward consultant is not to really have fixed meal times. It's, people generally tend to nibble when they get to that stage of dementia. So having carrot sticks or breadsticks or things that they could actually feed through the day is one better way of trying to keep nutrition going.
That's a really good tip, Raja. One thing she does say, it's more about coordination and feeding. So I think what you said about going back to the team is really important, because they'll also investigate that there isn't another cause for that happening at this stage as well.
Yeah, absolutely.
Thank you. I feel like I'm cutting you short, and I feel very rude doing that, but I know our time's about to run out. And we will be back, won't we? First Thursday of next month.
We will certainly be back, and I'm very happy to take questions that get sent to you, and then we could have a discussion as to how to send the replies back. Yes.
Yeah, that's great. So do send in questions for us, and we will look at them. We'll have a chance and we'll get back to you as soon as we can. Catherine, if you want to send in more information to us, you're more than welcome to do. Don't forget our free online sessions that we're running throughout the year. They're on our website, and everyone is more than welcome to book onto them and to look at the other resources that we have in the website. Raja, just again, thank you so much for joining us. I know our next session is going to go more into the diagnosis and the different forms of dementia, as well as the emotional support if someone gets to that stage. And then as you said earlier, the third session will be on medication choices for the different forms of dementia and different treatments. So thank you everyone for joining us today. It's been a pleasure to be joined by Dr. Raja, and we hope it's been of use to you, and we look forward to any further comments that come in from you. Thank you so much.
Thank you so much, Sue. See you in a few weeks' time.